afternoon session is going to focus on the changing landscape of new and emerging therapies. Our first session is going to be presented by Dr. Lon Schneider, who'll be joining us in a pre-recorded presentation. He's actually in London at a conference this weekend, so could not join us in person. And he's going to speak about emerging therapies. Dr. Schneider is professor of psychiatry, neurology, and gerontology at the Keck School of Medicine and the Leonard Davis School of Gerontology at the University of Southern California. His work involves treatment developments with new metabolic and neurogenic compounds, outcomes assessment, and approaches to modeling. He runs the clinical trials program at USC, and he served on the Lancet Commission on Dementia Prevention, Intervention, and Care, and he's published extensively about the use of medications in older adults and in dementia. So we're going to have Dr. Schneider join us in our pre-recorded session, and then if you have questions regarding Dr. Schneider's presentation, I ask you to write them down and save them for our panel of physicians who's going to join us for our closing session later this afternoon.
Hey, good morning. I'm sorry I can't be here today live, but thank you for having me. Hey, good morning. I'm sorry I can't be here today live, but thank you for having me. I'm going to speak a bit about emerging therapies for early Alzheimer's disease, and I hope at the end of the presentation you'll have a better idea of current therapeutic options and a bit about what's in store for the future. First, my disclosures. I believe these disclosures are largely printed in your booklet and in the slide handout. I receive, and USC receives, grants from NIH, from a number of other organizations from the state of California, and also from pharmaceutical companies. I'm involved in the Lancet Commission on Dementia Prevention and Care, and also receive funding from the Della Martin Endowment and Foundation. So with that, I'm going to proceed and discuss what I will talk about. And in this presentation, I will discuss the amyloid cascade theory because it drives the emerging therapies in Alzheimer's disease. I'll discuss the rationale for why amyloid beta targeting antibodies are now approved by the FDA for treatment. And then I'll go on to describe what early Alzheimer's disease is, what the criteria are for early Alzheimer's disease, because that is the indication for current new treatments. There are 3 antibodies that have been approved for FDA marketing, Aduhelm, Leqembi, and possibly even as I speak, donanemab has been just approved by FDA. One of them, Aduhelm, although approved and marketed, just recently the sponsor of the drug, Biogen, decided not to actively market the medication and turned it back to the original discoverers. So in effect, lecanemab and donanemab are the 2 choices of antibodies that we have available now. And then towards the end of the presentation, I'll discuss Leqembi or lecanemab treatment at Keck as we do it, and what the future has in store for us with respect to therapies. My bottom line, kind of upfront, is that lecanemab or donanemab could be therapeutic options under some conditions. Okay. Now, the amyloid cascade hypothesis. This has been the predominant theory of Alzheimer's pathology over now nearly 30 years, and it's from the amyloid cascade hypothesis that drugs are currently developed, and from which the antibodies have been approved. The amyloid theory comes from observations that amyloid beta peptide and amyloid beta protein are causative factors, not the only factors, but still are essential factors in the development of Alzheimer's disease. The basis of this involves dominantly inherited Alzheimer's disease, the inherited form, which is due always to a mutation on the amyloid precursor protein gene, or on the presenilin genes that are coding for gamma secretase, which is an enzyme that cuts amyloid precursor protein. So an abnormal gamma secretase can also be essential and seminal for the further development of Alzheimer's disease. The consequence of these mutations are increases in abnormal amyloid beta production, of A beta aggregation, and then inflammation and neurodegeneration. The other part of the amyloid cascade that's worth thinking about or discussing is the role of some risk factor genes, particularly apolipoprotein, the apolipoprotein gene, and the allele called the E4 allele. People who have one copy of the E4 allele have a somewhat greater risk for developing Alzheimer's disease later in life, in their 70s. People who have two copies, who are ApoE homozygotes, have a greater risk, a pretty good risk. Still, they probably will not develop Alzheimer's disease later in life, but the risks are greater than if you have just one ApoE4 allele. These genes, these proteins that come from ApoE, are remarkable in that they appear to increase amyloid beta deposition in plaques. So they're associated with it with a greater increase in plaque deposition and in the trafficking of amyloid than if you don't have, carry that gene. So these kinds of considerations inform the amyloid cascade hypothesis, inform the idea that an accumulation of pathogenic amyloid beta peptides leads to progressive synaptic and neuronal injuries, and then to hyperphosphorylation and destruction of neurons and the expression of phosphatase protein, and to further widespread neurodegeneration. So it stands to reason that an anti-A beta intervention could halt this process. The other key and consideration in the development of Alzheimer's disease is that the amyloidosis, the accumulation of amyloid, takes decades until it starts to show symptoms. Much of the time it actually doesn't show symptoms, but when it does, it takes decades of accumulation, 1 or 2 decades of accumulation, for that to happen. So the pathology of Alzheimer's disease evolves years before the clinical onset. A framework that we use to then describe Alzheimer's disease, a relatively modern framework, is to talk about people who are at risk for Alzheimer's because, who are at risk for Alzheimer's disease, perhaps because we can see amyloid plaques in their brains by PET scan. We talk about preclinical Alzheimer's disease, where there is a high density of amyloid plaques, and there may be an expression of phosphatase through towards the cortex of brain in older ages. And this kind of preclinical setup is without symptoms. So we have the idea of preclinical Alzheimer's disease is amyloid plaques without symptoms. Prodromal Alzheimer's disease, or MCI due to Alzheimer's disease, where there are plaques, there is a tauopathy. And there are now symptoms of predominantly memory loss. We go on to think about mild Alzheimer's dementia, where there is also, in addition to cognitive impairment, some impairment, however mild, in activities of daily living, in usually functional activities, getting around town, using instruments, and usually that and cooking. So, and then we talk about more severe Alzheimer's disease, dementia. Okay, now to switch to the antibodies, which is really what I wanted to speak about. And that is that the antibodies have been developed and raised in order to target amyloid beta and to reduce plaques and to reduce the oligomers, the chains of amyloid beta, in the hopes that this would then alter the course or improve symptoms in people with Alzheimer's disease. What the three antibodies that were marketed have in common is that they attack the amyloid beta at the N-terminal. A peptide has, or a peptide or a protein has an N-terminal for nitrogen and a C-terminal for carbon. And what you can see in this figure here are the three marketed antibodies that attack the N-terminal of amyloid, of the amyloid proteins. Antibodies that were developed to bind to the C-terminal or the mid-domain of an amyloid peptide have not proven to be effective. So there's a specificity here that is involved in the reduction of amyloid plaques, in the reduction of fibrils. The way this works is that the antibody binds to the amyloid plaque, and then microglia, which are cells that are involved in inflammation, perform a bit of a housekeeping function in the central nervous system. Microglia then phagocytose that combination of the antibody and the amyloid. It essentially attaches itself through what's called the Fc gamma receptor, and then disposes of the antibody and the amyloid peptide. The effect of this is to decrease plaques and increase CSF and plasma levels of amyloid beta 42, the monomer, the single monomer of many. At the same time, it will decrease CSF and plasma tau and phospho-tau. And this is a consistent biological finding, and this is what how the antibodies were developed and what we were looking for. So in summary, the antibodies are IgG1. They bind to the N-terminals of A beta. They are phagocytosed by microglia, and they reduce plaque and phospho-tau. The antibodies that are approved, and their timeline is here. Aducanumab, Aduhelm, was approved in June of 2020. Lecanemab, Leqembi, was approved fully in July of 2023, and donanemab just this month. I want to now give you an example of what we see with the antibodies in phase 3 clinical trials. With lecanemab, with Leqembi, the phase 3 pivotal trial was to randomize 1,795 patients, 1,800 patients who had mild cognitive impairment due to Alzheimer's disease or mild Alzheimer's dementia. They had to have a positive amyloid PET scan, as we discussed before, and they could only be mildly cognitively impaired with mini mental states of 22 or more. They were randomized to medication, to lecanemab 10 milligrams every other week by IV infusion. So patients came into the infusion center and received antibody every other week. It takes about 45 minutes or an hour to do this infusion. Or because this was a clinical trial, they randomly received placebo. They were followed for 18 months over time, and over that time, their side effects were monitored. Some people may have dropped out. Some people did develop side effects that we'll talk about in a moment. And at the end of 18 months, there was a positive effect on the primary outcome. The primary outcome is the Clinical Dementia Rating Scale sum of boxes or box scores. Clinical Dementia Rating Scale is just a 0 to 18 point way of rating the extent of cognitive impairment and dementia. Secondary outcomes was the amyloid PET scan, the ADAS-Cog, which is a measure of a neuropsychological composite measure of memory, language, orientation, and other functions, and two other outcomes, including a measure of activities of daily living. Cutting to the chase, all of these outcomes were positive in that the lecanemab group was superior to the placebo group at the end of 18 months. And I'll show you that in a bit of detail. At the same time, over those 18 months, patients were carefully monitored for safety, and MRIs were done essentially every at 2 months, at 3 months, at 6 months, and later. So patients with randomized to lecanemab tended to be with early Alzheimer's disease tend to be younger than people with Alzheimer's disease dementia. Their average age was 71. Half were women, as in most studies, in most clinical trials, the majority were Caucasian or of European descent. Most of them had mild cognitive impairment. Only about 40% or so had mild dementia. And as I mentioned before, ApoE4 is a risk factor for Alzheimer's disease, and nearly 70% of patients carried an ApoE4 allele. Patients were fairly typical of older people, of 71-year-old people, in that half had hypertension, 2/3 had high cholesterol, 15% had diabetes, 16% were significantly overweight. And here is an illustration of the outcomes in the key lecanemab trial that allowed a full regular approval last July. You see them here organized graphically. The CDR, the primary outcome, as you see, patients continued to deteriorate on average. These are just slopes of the average of about 850 patients in each group. But on average, patients deteriorated, whether they were on medication or placebo. You see these lines are really kind of parallel, and here is the Leqembi line in green, such that at the end of 18 months there was about a 0.45 point difference, about a half a point difference on the CDR sum of boxes. Similarly, on the cognitive test, the ADAS-Cog that measures memory, language, orientation, spatial orientation, for that matter, and some behavior, you see also that participants in both groups worsened a bit over time. These are actually relatively mild degrees of worsening, but you see that incrementally people on lecanemab were doing better. Similarly, with activities of daily living, you see that. Perhaps it seems as though there tends to be a divergence of the slopes towards 18 months here. Just a couple of points on activities of daily living, but statistically significant. What the key finding, though, is this marked effect on plaques. People on placebo, on amyloid plaques in the brain by PET scan, people on placebo stayed exactly the same as we would expect. People on medication show a sharp drop off and a sharp reduction of about 60 some points on the scale we use on the Centiloid scale we use to measure amyloid plaque. This is a really strong effect, and it tells us that the treatment is doing exactly what it was intended to do. And similarly with biomarkers, with amyloid PET again, with phospho-tau and total tau and other biomarkers of the glial cells. I mentioned astraglial cells and indications of inflammation, and neurogranin, which is a measure of synapses. You see marked changes in those biomarkers. The neurogranin suggests that some synapses are being spared. The decrease in GFAP suggests that inflammation is being reduced. So you see these marked biological effects, although the clinical effects were fairly small. Something we don't understand is that brain volumes also decreased. The total brain volume decreased, that the gray matter, the cortical thickness of people's brains decreased. Their ventricles got increased as brain volume decreased. There was a slight increase in hippocampus, which is an area that is associated with memory, and so that is going in the expected direction. But the decrease in brain volumes we don't understand, especially when you see this small improvement in cognition. Okay, shifting to adverse events. The long story short is that there are three main groups of adverse events to be aware of. Infusion reactions, what we call amyloid-related amyloid-related edema and amyloid-related hemorrhage. These are the three areas to be focused on. And one particular concern, cutting to the chase, is that the edema and or the hemorrhage could be severe enough that 1% or so of patients may need to be hospitalized for treatment, for essentially observation and perhaps steroid treatment to reduce the edema. I wanted to get that up front. It's about 1%, a little bit less. Because besides that, if you put that aside, then the edema and the hemorrhage that does occur is almost always, for the most part, asymptomatic and resolves in a few weeks. But sometimes it doesn't. A closer look at the infusion reactions, and that is that we will get an infusion reaction about 26% of the time. It tends to be mild to moderate. There's some inflammation around where the medication was infused. Sometimes there is other redness, and occasionally there might be a fever. The infusion reaction happens, for the most part, only one time. 65% occurs only one time and doesn't occur afterwards. But there again, 1% of the time, it could be serious and it could require hospitalization and some treatment with steroids. So this is a key adverse event to be concerned with. Again, the big picture is that 65% of the time it occurs only once and resolves, and about 85% of the time it still resolves and is relatively mild. Okay, our edema, our amyloid-related imaging abnormalities that we see on MRI. Most of the edema, as I mentioned before, is asymptomatic, and this is why we need to follow it with frequent MRIs. The rate of edema overall with lecanemab is about 12 or 13%. It mostly occurs in people who are ApoE4 carriers. 32% of of edema occurs in the risk is 32% in people who are homozygotes for ApoE4, 10%, 11% if you just carry one E4 epsilon 4 allele, and if you are not an ApoE4 carrier, the rate of edema is about 5%. The edema tends to occur early on in the first 3 months of treatment. You see that here in the ApoE4 carriers. Here are the ApoE4 heterozygotes, and here are people who are not ApoE4 carriers. So you see this big difference in risk. It occurs early, and then the rate tends to be rather low certainly after 6 months. For the most part, it is mild to moderate, and as I mentioned, 80% of the time asymptomatic. When there are symptoms, there's headache, visual disturbances, and confusion. You probably cannot see this, but these are illustrations on MRI of mild edema, this white area here, and this is a more moderately severe edema where the length of the edema is about 5 centimeters or 2 inches, maybe a little bit more, but that defines it. Still, in these cases, there was resolution usually over about 4 weeks, sometimes 8 weeks, and the edema regresses. The amyloid-related imaging abnormalities for hemorrhage, the type of hemorrhage that tends to occur is what we call microhemorrhages. These are dots of bleeding that is less than a centimeter wide. Just to show you the pictures first here, a mild microhemorrhage looks like this, if you could hopefully see it. If it's more moderate, there are more examples of the hemorrhage in different places around the brain. Hemorrhages occur with lecanemab 17% of the time, microhemorrhages. However, it's important to know that even in placebo over 18 months, a 71-year-old, 9% will have hemorrhages. They occur spontaneously. They are sometimes often related to hypertension. And again, with relatively speaking, with lecanemab treatment, they tend to be asymptomatic and mild. Hemorrhages don't regress; they just stay there. They are more common in ApoE4 homozygotes, and there is some controversy about whether they are more common when people are on anticoagulants. Hemorrhages that occur with edema are of more concern than those that occur without edema. I just wanted to switch over to donanemab for one brief moment to show you by picture that what the phase 3 trial looks like and how it's very similar in terms of outcome to lecanemab. in terms of clinical outcome on the CDR sum of boxes. You see this about 0.7 difference. And you also see how it is extremely potent at reducing plaques. It actually reduces more plaques than lecanemab, but we're not certain that that actually is associated with a better clinical difference or lessening of worsening. So, what you should know about treatment with lecanemab is the following. The efficacy is modest, as I showed. Both placebo and drug groups decline, but the drug group, the lecanemab group, somewhat less so. The effects can be measured in larger groups of people on composite scores, on cognitive or neuropsychological scores, and on in instrumental activities of daily living. There are the large effects on the biomarkers indicating that the medication is doing, the treatment is doing what it was designed to do. Bust plaques and reduce phosphatal as well. The adverse events are the infusion reactions, edema, microhemorrhages, and about 1% of the time they are severe. There is a black box warning that asks clinicians to discuss with patients the risks for the amyloid-related imaging abnormalities and the particular risk, the higher risks if you're an APOE4 carrier. The challenges to treating with lecanemab and donanemab, this applies for both, are that it's a complex procedure. It involves infusions over time. It involves frequent visits, either twice a month for lecanemab, once a month for donanemab. This in itself creates barriers to access and diversity, but then to get the medication, you need infusion centers, you need to have access to infusion centers, and you need to have access to physicians as well. Threats to the effective treatment with these medications involve missing doses and non-compliance because of the frequency of having to come in to get the infusions. About 15% of patients in the studies did drop out over the course of 18 months. And the benefits, the beneficial considerations are largely rely on our thoughts that plaque reduction and improved clinical management will ultimately lead to a beneficial effect. So to that end, there are prevention trials that are ongoing with lecanemab and donanemab over the course of about 4 years to see whether giving lecanemab or donanemab compared to placebo over this period of time to people who are asymptomatic but have plaques might show overall long-term effectiveness. And this is in effect what we want to see and what we're waiting for and hoping for over the next few years. Okay, lecanemab at USC, would I qualify? I described for you the inclusion criteria for the phase 3 trials. These are the eligibility criteria for clinical care. They involve mild cognitive impairment and mild dementia. When the Mayo Clinic looked at the Rochester, Minnesota population, long story short, they were only able to find 5 to 8% of people with dementia, with Alzheimer's disease, and with essentially mild early Alzheimer's disease, 5 to 8% of people who, when all is said and done, would qualify for lecanemab. So there again is a barrier to treatment. Many people are too severely impaired with in the course of their illness to benefit from lecanemab, and others have concomitant illnesses that may be or conditions that may be contraindications. At USC, we've got an organized set up for evaluating and treating patients for amyloid targeting antibodies. People receive evaluations that involve ApoE genotyping, MRI imaging, and amyloid PET imaging to see that you are carrying, that you do have amyloid plaques to treat. There is financial counseling. Infusions, again, are every 2 weeks, so the commitment is for a year and a half for 36 infusions. We monitor carefully MRIs every 2 months, 3 months, 6 months, and there are frequent clinician visits. So that's what I wanted to discuss. I did run over by the 5 minutes now, so I apologize for the length of this discussion. But in summary, it's the amyloid cascade that drives our therapeutic development. Amyloid targeting antibodies are similar to each other. I described previously how they work and how microglia phagocytose the complex. It is indicated for early Alzheimer's disease, for people with early Alzheimer's disease diagnosis. There are 3 antibodies on the market. There are outcomes, or I discussed the outcomes and adverse events to expect, and what's involved with treatment. And finally, as I said before, it's the ongoing preclinical Alzheimer's disease trials that will help to define the utility and the broad range of use of this treatment in a few years, and essentially define just how valuable it might be. Looking towards the future, additionally, we're moving to an era where we are defining Alzheimer's disease more by biomarkers and phenotyping than we are by clinical assessment. In terms of further therapeutic development, we are looking at antibodies and treatments directed against the abnormal tau proteins, anti-inflammatory approaches, and approaches that may alter or improve the function of the microglia, because it might actually be the microglia that are causing that are involved in the therapeutic response. So that's what I wanted to discuss. At the same time, I just wanted to remind you that there is much that can be done to actually prevent Alzheimer's disease and decrease its onset in middle life, in late life, including managing hypertension, obesity, managing hearing loss, avoiding traumatic brain injury, avoiding excessive alcohol, not smoking, and maintaining physical activity. And finally, not the least, but the hardest perhaps to do, is avoiding the degree of air pollution that we tolerate here in Southern California. So thank you for your attention. At USC, we have an active Alzheimer's research program, and you can find out more about that online. Again, I apologize for going over 7 minutes. I hope, though, that this was worthwhile to you. So thank you.